All right, and we will continue the program after this wonderful presentation. And we will talk about the coarctation of the aorta mostly in this talk. And I would like to emphasize the differences between the true coarctations and the other clinical conditions that can mimic coarctation during our examination that makes the diagnosis of the coarctation extremely difficult on the fetus. And as we discussed the other speakers just now, that the coarctation unfortunately is not very easy diagnosis to make, and the rate of the false positive and false negative results is still very high. So, but we will try to see how the classic presentation will be of the coarctation in our ultrasound exam and more unusual cases as well. So aortic coarctation, by definition, this is the narrowing of the aortic arch, typically narrowing of the aortic isthmus. This is the region between the left subclavian artery and the ductus arteriosus. Also, sometimes the narrowing may include not just one local place, but the entire aortic arch, and can be termed the tubular hypoplasia of the aortic arch. This is a relatively common abnormality and accounts about 10% of all congenital heart anomalies on the newborn, and very often resulted in the life-threatening condition that requires surgical attention right after birth. So here is the anatomy of the aortic arch, just a reminder that we can see different regions of the aorta, starting from the aortic valve, then we have the ascending aorta, aortic arch, head and neck vessels, and then the descending thoracic aorta and abdominal aorta. And here on the anatomical specimens taken from the fetus, you can see that there is a very wide connection between the pulmonary artery and the aorta. This is the ductus arteriosus that very often gets on our view, and it's not very difficult to diagnose coarctation while the ductus arteriosus is widely open. So in correlation with the anatomical view that we just seen on the previous slide, this is the ultrasound appearance of the long axis of the aorta, where again we start from the valve, then we have the ascending region, and then we have the arch, the head and neck vessels, then we have the isthmus and the descending aorta. And here in the color Doppler we can see all those regions that we're supposed to see very nice laminar flow, and not supposed to see any narrowing or turbulence in the blood flow. And as was said, that the coarctation typically occur at this region between the left subclavian artery and the area where the ductus arteriosus joins the descending aorta, and may include the entire aortic arch. So, how coarctation typically presents on our ultrasound examination. Remember that we start from the 4-chamber view in our screening settings, and already at the level of the 4-chamber view we can see something suspicious for coarctation. And the first thing, we can take a look at this 4-chamber view, and if I ask you which one would you prefer to have, I'm sure that you will tell me that this one is the one that would be great to have. So, and what's the difference? The difference is that here we have the discrepancy between the left and the right side of the heart. We have the left side being smaller, appearing smaller than the right side, and this is a very first sign of the coarctation that can be seen at the level of the 4-chamber view. But don't forget that the 4-chamber view and discrepancy between the chambers, especially left and right side, can be seen in many other conditions. And indeed, the left side of the heart may have a normal size and the right side can be enlarged. So in this case, it's very useful to take some measurements, in particular the Z-scores of the inlet portions of both ventricles and the EV valves, such as mitral and tricuspid, to determine if the left side is really small or the right side enlarged. So that is important for differential diagnosis. And so four-chamber view demonstrates the narrowing of the left ventricle, and the shape of the left ventricle in settings of coarctation is very typical. In contrast to other pathologies that may involve the left side of the heart, the left ventricle in settings of coarctation has a very narrowed and fusiformed shape, and usually it still reaches the apex of the heart and contribute to the formation of the apex of the heart. Usually in coarctation, the contractility of the left ventricle is normal, and we can see sometimes reduced but still antegrade flow across the mitral valve. If you put color on and compare four chambers here, we can see that in normal condition we have very symmetrical two equal inlets. So the flow across the mitral and tricuspid valve is very laminar and pretty much the same in size. In settings of coarctation, as I said, the antegrade flow across the mitral valve is still preserved, but the inlets look very asymmetrical, confirming the same finding in the 2D. If you look at the left ventricle outflow tract in normal situation and in the settings of coarctation, you can see that sometimes the outflow may look a little bit narrowed, and aortic valve sometimes could be thickened. Sometimes you can see that the valve is narrow too, and the ascending aorta could be involved in some cases as well. Color Doppler use usually allows to recognize the normal antegrade flow across the valve. But if you look at the aortic valve in the cross-section, very often and very common finding that we can detect, this is the presence of the bicuspid aortic valve. So this is two patients that coarctation. This patient has the three cusps in the aortic valve, showing the very typical Mercedes appearance of the three leaflets. And here we have a typical presentation of the bicuspid aortic valve, where we have just two leaflets here. So if you happen to suspect or detect the bicuspid aortic valve, the aortic arch needs to be examined very carefully because it goes along with the coarctation very often. And finally, we are moving to the direct visualization of the aortic arch, and as Dr. Abu Hamid pointed in his talk this morning, that for diagnosis of different anomalies of the aortic arch, the three-vessel trachea view has a very important role, and probably without this view you won't be able to detect many of those malformations. So here we have again normal fetus and fetus with coarctation. So what the three-vessel trachea view usually demonstrates. So remember that the size of the big vessels, pulmonary artery and the aorta, is pretty much the same, and the vessels are aligned along that oblique line that goes from left to the right and from anterior posterior direction. So in the settings of coarctation, three-vessel trachea view demonstrates first the discrepancy in size between the pulmonary artery being significantly larger than the aorta, and also sometimes ascending aorta may appear even smaller than the appearance of the superior vena cava. At the same time, that hypoplasia, that smaller aortic arch, seem to be displaced more posteriorly towards the spine, so the vessels are aligned along the triangle, the apex pointing backwards, other than, as the aligned along the line. So the discrepancy in size and the level of the three-vessel trachea view is more specific for coarctation. And if you saw disproportionate the level of the four-chamber view and see the disproportionate the three-vessel trachea view, you need to suspect the coarctation right away. Then we put color on. You can see here the 2D image of the three-vessel trachea view and the three-vessel trachea view with color Doppler. Even though the blood flow is still going the same direction, you can see that the aortic arch in this view demonstrates a very high velocity turbulent flow that is suggestive for the tubular hyperplasia of this aortic arch. And the spectral Doppler could be very different, and there are several authors that recommend to spectral Doppler, the aortic isthmus in differential diagnosis for coarctation, so that could be additional marker for diagnosis of that pathology. So here we have a different fetus, also the narrowing of the aortic arch, and as you can see that the isthmus and the all transverse arch is significantly hypoplastic here, and it's so small that blood flow across this region is not enough for delivering enough blood flow to the head and neck vessels. So then the obstruction is very significant. You can see the phenomenon that you observe in the hypoplastic left heart syndrome. Then there is the reversal flow in the aortic arch, providing extra blood flow for the head and neck vessels and the coronary circulation. And finally, we can obtain the view that is sagittal, demonstrating the long axis and the long axis of the aorta. And here we have the ascending aorta, we have the transverse arch, and here we have the shelf sign at the level of the isthmus, and here we have ductus joining the descending aorta, and this is the left subclavian artery, and this region is very small, and you can see this pinch at this region called shelf, and this is the classic presentation of the coarctation in ultrasound. Unfortunately, it can be seen not always, and as soon as the ductus is widely open, not easy to get the slice that shows just the aortic arch without inclusion of the portion of the ductus arteriosus that can mimic the normal appearance of the aortic arch in this view. Aortic arch can be, the isthmus in the aortic arch can be elongated and have that very twisted course, as you can see here. Again, typical for coarctation, we have the turbulence at that level, and we can see that the narrowing occur not just in the local area, but involves pretty much the entire arch. And this is another example demonstrating the reversal flow across the isthmus, also in the patient with the critical coarctation confirmed at the neonatal period. We can use all technologies available for us, and this view demonstrates another important marker for the coarctation. So in many fetuses with coarctation, we can see that the left subclavian artery is significantly displaced downstream in relationship to the other head and neck vessels. And here we have that extra distance that is demonstrated by this B-flow technology. And if you see this marker, you also may think that this is something that pointing towards the coarctation. And this is the other case, again showing the narrowing of the arch, and this is the inversion mode that Julia demonstrated in her talk, that technique can be also useful for diagnosis and confirmation of the congenital heart anomalies. And you can compare how thin the isthmus is in comparison to the area downstream where the ductus arteriosus already connected to the descending aorta. So a few slides regarding the differential diagnosis of the coarctation and other left heart lesions, such as the hypoplastic left heart syndrome. So four-chamber view shows significant difference in the appearance of the shape of the left ventricle. So for hypoplastic left heart syndrome, we will see the left ventricle usually has a very globular shape, never reaches the apex. Here the apex is formed by right ventricle. Usually endocardium is very bright, and we have significant decrease in the contractility. At the same time, the foramen valley and the flap travels back and forth, and mostly seen in the right atrium, that suggests the reversal flow across the foramen valley. In settings of coarctation, usually we have, as I said, the fusiformed, very narrow shape of the ventricle. Mitral valve is patent, and we have the appearance of the foramen valley flap still in the left atrium with the right to left blood flow across the foramen. So color Doppler in coarctation, in contrast to the hypoplastic left heart syndrome, will show us the direct flow across the mitral valve, while here we will be able to see the filling only on the right side across tricuspid valve. So for hypoplastic left heart syndrome, it's very typical to have complete atresia of the aortic valve and no evidence of the direct blood flow across the aortic valve, in contrast to the coarctation where that will be still preserved. And now we will take a look at the few cases. And the case number 1, we have the 4-chamber view here. And you may ask me why I included this case in the presentation about coarctation. So here we have no evidence of the narrowing of the left side of the heart, so that the heart is actually overall enlarged. So, but we will see how that diagnosis can be made in this case. So here we have pretty normal 4-chamber view. If we put color on, we can see something unusual. This is something that should make us look at this heart very carefully, because usually mitral regurgitation or mitral insufficiency are not very often seen in the normal heart. And here we have quite a lot of the mitral regurgitation. So then you see regurgitation, you want to take a really close look at the valve and see if the valve is opening and closing appropriately, if the anatomy of the valve is normal. And here we have something in between the inflow and outflow. You can see the aortic root here. You can see the ventricular septal defect. And this is probably explains why the 2 ventricles shows no evidence of the discrepancy, because the VSD pretty much allows the blood flow in both ventricles equally and allowing to grow for both chambers appropriately. Once again, we are looking at the mitral valve. We can see that the valve somehow redundant, and that the leaflets have connection to the one side of the ventricle, so that the valve is not really opening appropriately. And then we looked at the short axis. In this case, we were able to detect just one group of the papillary muscle, and this made this valve called the parachute mitral valve. So here we are looking at the outflow tracts, and you can see that there is significant discrepancy in size of the pulmonary trunk and the ascending aorta, and of course we can confirm that there is a large perimembranous VSD. And here is our 3-vessel trachea view, and this is probably the key to our diagnosis. So we can see that pulmonary artery is dilated, that the aorta is very difficult to find. Only use of color Doppler allows us to visualize continuous flow in the aortic isthmus, and we can connect the ascending aorta to the descending aorta, and that the entire aortic arch is very small and hypoplastic. And this is the view of the aortic arch. Sagittal view showing how narrow the arch is, and again how dilated and how big looks the ductus arteriosus in comparison to the transverse arch. So what was the diagnosis here? So also that patient has a very strong family history of the abnormalities on the left heart, so that the father of the baby had a coarctation, and the grandfather of this baby had actually bicuspid aortic valve. So, and here we have that arch in the in color, again demonstrating how narrow the arch is. So, and in this case, we diagnosed Schwann complex. So this is the group of the malformations that are typical. Then we have the parachute mitral valve and some kind of obstruction of the left outflow tract, including the subvalvular membranes or bicuspid valve or coarctation. So that was a very interesting observation. And the point here is that if you can see discrepancy at the level of the 4-chamber view, that can be due to the VSD, which is a very common associated malformation in coarctation, and only aortic arch views may confirm that the aorta is narrow. So now we are moving to a different case that we had recently. So the patient had a normal screening with us, and in the 3rd trimester was sent the slight discrepancy between the chambers. So if you look here, so, well, you may suspect that the left side a little bit smaller, but in the 3rd trimester it's very typical that the right heart dominance is present. So, and then we looked at the 3-vessel trachea view, and we saw all the features which are typical for coarctation. So, and we even were able to see the reversal flow in the aortic isthmus, and the first diagnosis was the suspicion of coarctation. So then you see something like that. Then it was absolutely normal in the second trimester. In the third trimester, you have this picture. So the first thing that I would advise to ask or take a look at, how big is the baby? Because as we all know, on the fetuses, there's growth restriction. So we may see the phenomena then the blood flow in the aortic arch or ductus arteriosus can be reversed in order to compensate for redistribution of the blood flow then in the very severe stage of the growth restriction, so that the blood would go primarily to the heart itself and the brain. So, and this condition should not be mistaken with the coarctation of the aorta. In addition to the significant growth restriction in this case, baby also had an abnormality of the distribution of the branches of the aortic arch. You can see here that the brachiocephalic, right brachiocephalic artery and left common carotid, they have the common origin, and the next vessel is the left subclavian artery, so that this is a type of the bovine arch, and that's why we observed that in this case the aortic isthmus, even without growth restriction, always looks significantly smaller than the normal fetuses. So in here you can see the history. So at the time that the coarctation was suspected, so the fetus had fetus was very small overall and also had abnormal parameters on the maternal fetal Dopplers, so that the reversal flow in the umbilical artery was delivered soon after, and after birth we had no evidence of coarctation on this fetus. And so this is something to keep in mind, that if you had a normal screen at the mid-second trimester and you suspect the coarctation in the third trimester, so that most likely this is the false positive result, and the reversal flow that you can see in the isthmus most likely related to the other problems. And we are moving to the next case. Again, in the third trimester, the patient presented with this appearance of the four-chamber view, fit the criteria for coarctation 100%, very narrow and thin left ventricle, right? But let's take a look, very careful look at the left atrium here. So we can see that there is like the aneurysmal flap of the foramina valley that takes pretty much the entire volume of the left atrium. And it's so significantly protruding through the towards the left atrium that the blood flow across the mitral valve is significantly restricted. And if you look how narrow the left ventricle is, like your first move to suspect the coarctation, right? And this is the free vessel trachea view. And this looks quite unusual. So we have a very dilated pulmonary artery. There's a huge bulge here, which is the large ductus arteriosus aneurysm. And if we look at this arch, we can see that this is the ductus arteriosus aneurysm, which is huge. And in comparison to this area, the isthmus looks very narrowed. So surprisingly for us was then the baby was born and the echo was performed. Nothing was found. The thing that now, this huge aneurysm just completely collapsed, and foramen was completely closed, and as soon as baby started breathing, so the left ventricle just expanded, and there were no evidence of discrepancy and no evidence of any problems at all. And our neonatologists were very angry with us that we suspected coarctation, and they have to do all those manipulations, and that was perfectly normal baby. So this is just to demonstrate how difficult the diagnosis of coarctation can be, in particular if you have the patient referred in the middle of the third trimester. So this is just to demonstrate how huge that aneurysm was, right? So here you can get the sagittal arch sometimes because the ductus is so huge. So baby had the incidental finding of the polydactyly. Okay. So the karyotype was normal. And also what we noticed, it's not published data yet, but just based on our experience, if you have significant dilation of the ductus, if you have very massive ductus arteriosus aneurysm, usually it excludes the possibility of the coarctation. So that is also an important thing to remember. So to conclude, to take home message is that the aortic coarctation can be suspected at the level of the 4-chamber view. Then you see a discrepancy, but that is not specific. In the longitudinal view of the aortic arch, you can see narrowing of the aortic isthmus, the very typical appearance of the coarctation shelf, again, cannot be seen on every single patient. That the pre-vessel trachea view and appearance, then the great vessels have the discrepant size, is the very important and specific marker, in particular if you see discrepancy at the level of the 4-chamber view. Associated cardiac malformations are common in the coarctation, and the most common is VSD. And also the chromosomal aberrations is probably very well-known fact that the syndromes such as Turner syndrome are very common in coarctation. So if you suspect that there is a coarctation and the fetus is female, so that's very reasonable to do the genetics testing. And I think that this is it for coarctation, and I hope that that was helpful. Thank you very much.